Hello, my name's Tristan Barber. This talk is entitled Frailty and Accelerated Aging. When is 50 actually 70? Really, in the context of living long with HIV. These are my disclosures. So, when we think about someone with HIV who's getting older, what commonly happens is that they start to fall between the cracks of multiple different services. We see people struggling with their mental health, with issues around polypharmacy, of course, with issues around HIV itself, often with issues around basic needs and access to social services, having problems with multimorbidity and managing complex comorbidities, accessing primary care, and also sometimes having to access multiple outpatient appointments. Very often, people with HIV report that their HIV service is the one that they trust the most and where they'd like to see their services coordinated. But for HIV providers, this can be difficult. They may not always have the expertise to manage all of the complex problems that an older person with HIV is experiencing. We know that around the world, the number of people living with HIV who are aged over 50 years is increasing. In 2016, it was estimated there are around 5.7 million people with HIV who are over 50. And this proportion had increased substantially from 8% in 2000 and went up to 21% by 2020. In 2016, 80% of the people living with HIV who are over 50 lived in low and middle income countries. While the proportion is greater in high income countries, LMICs have higher absolute numbers, and this is expected to continue to increase. From 2000 to 2016, the proportions doubled in Eastern and Southern Africa, Eastern Europe and Central Asia, and Western and Central Europe and North America, but tripled in Latin America and the Caribbean, and quadrupled in Asia and the Pacific regions. Older people living with HIV, we know, experience higher rates of key comorbid non-AIDS events. We can see here in this graph how the proportions are expected to continue to increase in LMICs in particular, with a steady increase in high-income countries in addition, shown here in blue. If we don't take action today, we know that quality of life and actual lives may be lost. Many will struggle coping with multimorbidity and other chronic health conditions. You can see some of these listed here, including cognitive impairment, depression, social isolation, chronic pain, frailty, sleep disorders, disability, loss of energy, loneliness, and multimorbidity. Sometimes I think as HIV providers, we can feel we're unable to cope with the huge amount of problems people may experience as they get older. But I would argue that just by taking a little bit more time for those who are older and most complex, taking a full medical history rather than just focusing on HIV, we can often identify issues that it's relatively easy for us to help support or signpost people for further support with. We also know that people who are getting older with HIV may experience ageism in addition to HIV stigma and other forms of stigma and discrimination. So, what is frailty? Well, frailty is defined as a state of decreased homeostatic reserve resulting in an increased vulnerability to endogenous and exogenous stressors and an increased risk of negative outcomes. What this really means is that people who are frail have less ability to cope with environmental insults or other illnesses. So if you develop a cancer, if you have a fall, you may be less able to recover than someone who is not frail. Most of the research that has happened in this context relates to older men. We see here a man across the life course, and I think it's very important to remember that in women there are additional factors that can lead to premature frailty, including in the context of HIV, premature menopause. We must also not forget people who acquired HIV perinatally. These individuals, although their birthday age may be relatively young, can have been living, with HIV for many years. So if you acquired HIV perinatally and you're now 30, you can be the same as someone who acquired HIV horizontally at age 40, but is now 70. And this leads me to thinking not only about your chronological age, but also the length of time you've been living with HIV infection. When I'm thinking about what I'm talking about with regard to aging in the context of HIV, and when I'm thinking about an individual person with HIV in front of me, I tend to split people into four categories. Now, I'm using here the date of HIV diagnosis as a surrogate marker for the date of HIV acquisition. So if you were born before 1996, and of course these cutoffs depend on what country setting you're in and when you had access to antiretroviral therapy, but thinking of the UK setting, before 1996, this is when people didn't have access to successful triple combination therapy. You may need to adapt these dates according to your own setting in India. But for me, someone who was diagnosed before this date is someone who will have been told to stop work. They will have been told they might have a 3 to 5 year life expectancy. They may have had an AIDS defining condition. They'll certainly have had a long period of time of exposure to untreated virus and to immunosuppression. They'll also have suffered bereavement. They may have some post traumatic stress disorder, and their entire life has very often been affected by their HIV diagnosis. In 1996, at the Vancouver World AIDS Conference, we saw the presentation of successful triple antiretroviral therapy. Now, in the latter part of the 90s, there was therefore optimism about the success of treating HIV and giving people a better life expectancy. But nonetheless, treatments were complicated, often involving multiple pills. They had multiple toxicities, and some people still had a legacy of resistance from suboptimal treatment before triple therapy was available. And actually, in the early noughties from 2000 to 2005, some of this optimism went away as we saw an increase in triple class resistance, and we were worried that we were starting to run out of successful antiretroviral options. So, again, this group have been heavily affected by their HIV journey. As a consequence of the toxicity of antiretroviral therapy, guidelines were recommending that we waited to start treatment until a CD4 count of 200. So again, these people had prolonged exposure to immunosuppression and untreated viral replication. From 2005 to 2015, we had more successful treatment. We saw drugs that could treat resistance that had developed that could treat virus that had developed resistance previously. And we also saw much better tolerated triple therapy, including the first single tablet regimens. Now, as treatment was better tolerated, we saw a recommendation in guidelines that we moved up to a CD4 count of 350 for initiating treatment. From 2015 onwards, we've had the START study, and we've known that it's the right advice to recommend that anyone with HIV starts antiretroviral therapy regardless of their CD4 count. Now, I think you can see that you can be 70 and have been diagnosed in 1990. You can be 70 and have been diagnosed in 2020, and these are very different individuals. Their pattern of aging with HIV and the impact HIV has had on their aging are going to be incredibly different. And it's for this reason I recommend we don't only think about chronological or birthday age, but we think about HIV age in addition and how this plays into someone's risk factors for developing frailty or premature comorbidities. What's actually happening in terms of pathogenesis? Well, there are a number of factors in people with HIV that can feed into premature aging and premature frailty. We see issues with genetic variants. We see DNA damage moving around this clock, if you like, here. We see mitochondrial dysfunction. We see abnormal protein metabolism. We see abnormal cell metabolism. We see premature senescence. We see an impact on people's immune system. And we see chronic inflammation in addition. We know that HIV can affect the gut. We may see altered gut microbes. We may see altered gut permeability. We know that environmental factors like diet, alcohol, sedentary lifestyle, drug use, and smoking can, of course, impact on someone's aging. And we know that some of these things are more common in the context of HIV infection. And then finally, in red, of course, we see the direct impact of antiretroviral therapy and of HIV itself. HIV proteins may promote premature aging, and some older antiretrovirals in particular may contribute to a premature aging process. This is just a schematic to look at what we mean by chronic inflammation. We know that persistent inflammation and immune activation, which may be triggered even by very low level viral replication below the limit of detection on standard assays, have been linked to the increased frequency of age-related conditions in people living with HIV. In addition to lifestyle factors, this can contribute to persistent inflammation and may lead to the premature comorbidities we see listed in the yellow blocks on the right-hand side of this slide. When we think about frailty and how someone might appear with frailty, this is the so-called frailty phenotype. So we see an individual on the left who's robust. As someone becomes pre-frail, they may develop reduced muscle strength. They may have lower energy than someone of the same age as them. They may get exhausted very easily. And as they accrue more of these phenotypic identifiers, we see that people have a slower walking speed, they may have unintentional weight loss, and they're accruing more factors that allow us to label them as frail rather than just pre-frail or robust. And this can help us with screening for frailty. This is the modified Fried Frailty Phenotype score that we use at the Royal Free Hospital where I work in our annual screen to try and identify people early with frailty or pre-frailty. So we ask people in the last 12 months, have you noticed any of the following? An inability to grip with your hands, unexpected decrease or loss of weight that's worrying you, a slower walking pace than usual, not feeling full of energy for most days of the week, and this is a complicated one, being less or much less active compared with someone who spends 2 hours on most days on activities such as walking, gardening, household chores, or do-it-yourself projects. And people can indicate on here if they're experiencing any of these symptoms. Now, the limitations are that this score is subjective, it's not objective, and doesn't include objective measurements such as gait speed and grip strength. It also doesn't consider the broader elements of frailty, such as cognition and psychosocial functioning. But nonetheless, for us, if someone scores 3 or more on this score, it's an indication that we need to do a more in-depth assessment. We also have the Rockwood Clinical Frailty Scale. This is a visual scale where we can try and identify people's stage of frailty. Essentially, those who are in category 1 or 2 tend to be quite well. Those who are in categories 3, 4, or 5 tend to have mild or pre-frailty, and those in the higher categories 6, 7, 8, and 9 are frail by definition. And these are people who it's much more difficult to manage because reversing true frailty once it's occurred is much more difficult than trying to reverse the minor impairments that occur in pre-frailty. As I've alluded to, frailty doesn't need to be permanent. We know that frailty can progress, but if we intervene in the early stages with simple interventions, we can reverse pre-frailty and we can keep people well, independent, out of hospital, and with a better overall health-related quality of life. So again, I think sometimes we can feel quite hopeless, but what small practical steps can we do to reverse or manage pre-frailty? One of the first is improving physical function. So getting people to exercise, even if it's just walking, is incredibly important. We know that actually weight training as people get older is probably more important than cardiovascular exercise. And that's really because retaining muscle mass and muscle strength is incredibly important for older people. It's very often neglected, but even simple weightlifting, like using household objects, can help maintain lean muscle mass and avoid the development of frailty. We can also try and improve people's nutrition, and we can manage mental health problems, including mood disorders when they arise, as we know that people who are more motivated to be proactive about their physical health are better at avoiding frailty. We need to identify physical deficits. We need to identify comorbidities and other medical conditions and treat them when we find them. And where possible, we need to improve people's physiological reserve. These are some of the potential targets for intervention. I won't go through these individually. Some of these are probably harder to treat than others. I think loneliness and social isolation can be particularly hard for us as HIV clinicians. But identifying things like poor vision mean we can recommend people get simple eye tests. Just correcting their vision with regular glasses can be a huge benefit in terms of improving and avoiding frailty. For us in our dedicated frailty service, we've also found asking very simple questions about bowel or bladder continence can lead to very simple referrals to continence specialists who can help people manage their incontinence, recommend surgical intervention if necessary, but also recommend simple lifestyle modifications that can improve these symptoms, and this massively improves overall health-related quality of life. We also see studies now that are looking at avoiding some of the comorbidities people with HIV may develop prematurely as they age. The Reprieve study, presented now 2 years ago, showed us that abacavir can be associated with an elevated risk of cardiovascular events, but in addition, that treating people with statins or offering statins to everyone over the age of 40 can be associated with a reduction in major cardiovascular events, including heart attacks. Abacavir very rarely adds benefit to an antiretroviral regimen over and above the risks it may cause, so we're starting to see these trials that allow us to help people avoid comorbidities as they age with HIV. And I expect we'll see more trials looking at avoiding these chronic comorbidities as we move forward with further HIV research. Other therapeutic interventions to avoid frailty may also be useful. We're seeing an increased use of GLP-1 agonists in certain country settings, and avoiding obesity may be something that also may help people avoid frailty. Although, of course, we do know that GLP-1 agonists may mean that people lose muscle mass in addition to fat. And there are other pharmacological interventions that may be associated with a reduction in comorbidity burden, including metformin, potentially other novel anti-inflammatory treatments, specific treatments looking at reducing the effects of aging. But I would say, apart from pharmacological intervention, the best overall treatment to avoid frailty is regular exercise, and that must include some weightlifting to maintain muscle strength, not just cardiovascular exercise. In terms of antiretrovirals, I think we need to use antiretrovirals with the least potential for drug-drug interactions. We need to review older patients in terms of their co-medications and avoid complications of polypharmacy. And we need to bear in mind that with new medications, both for HIV and for other comorbidities, drug-drug interaction studies may not yet be done or may not be very clear. So we always need to be aware of the potential for drug-drug interactions. What we're really trying to aim for is good health-related quality of life. This is my terrible drawing here on the right-hand side. But we know, for instance, in the UK that 97% of people living with HIV have viral undetectability. We're now looking beyond viral load alone to make sure that we're providing quality healthcare in addition to viral suppression. And service delivery should always promote wellness rather than just survival. And this has been called the fourth 90. I would argue now it should be the fourth 95. But we're trying to ensure that as many people as possible with HIV have good health-related quality of life over and above viral suppression. So simple steps we can do in clinic. We often feel overwhelmed. We may not be able to do a frailty assessment in a very busy clinic, but what we can do is talk to people about their physical function and about their activities of daily living. We can do simple things like measuring and recording body mass index and waist hip ratio. We can chart these changes over time, and we can share data with colleagues to see what's happening with our older patients. And we can give simple lifestyle advice, in particular around exercise and diet. So in summary, frailty and accelerated aging do happen in the context of even successfully treated HIV. I think the HIV age matters just as much, if not more, than the chronological age. We know that inflammation may be a driver for age-associated comorbidities and for premature frailty. And we know that simple screening and interventions can reverse or avoid progression, helping to maintain independence and good health-related quality of life. What some people really need is some help with care coordination. And if possible, this is crucial if comorbidities cannot all be managed within HIV services. just checking that someone's able to attend all of their appointments, trying to co-locate blood tests within one drawer if possible, rather than people having multiple blood draws at multiple different locations, can really help with overall health-related quality of life and help with care coordination. We all deserve age-friendly and age-affirming information, care, services and support that considers not only the impact of our HIV status, but also our gender identity, sexual orientation, race and ethnicity. I think this overarching statement really gives us something to aspire to in terms of caring for older people with HIV. I didn't have time to cover it here, but I just wanted to highlight a fantastic session that was undertaken at Croy by Shibani Mukherjee from Massachusetts General Hospital in Boston on cognitive aging and assessment in HIV. If you have access to the Croy website or you ever get the opportunity to hear Shibani talk, this was a really, really wonderful session. Finally, as I'm here representing the British HIV Association as chair, I wanted to highlight that we do have international membership available for BEVA, which does offer benefits to those around the world, particularly in LMICs. Our current annual rate is around 3,000 rupees if you did wish to join from India, and further details are available on the link at the bottom of this slide. Thank you very much indeed for your attention, and I look forward to taking any of your questions on this talk in our discussion session.